Welcome back to the deep dive. Today, we're undertaking a really critical mission, actually. We're moving entirely past the pharmacology, the study of the drug itself, and focusing squarely on, well, the essential professional precision and the meticulous choreography, really, required to deliver that medicine safely into the patient. We're talking about protocols, rigid measurements, and the strict safety procedures that govern drug administration in any fast-paced clinical setting.
That shift in focus is absolutely crucial because when you, as a professional, prepare and administer a drug, you're not just carrying out an instruction, you become the ultimate steward of patient safety. Our sources today are designed to distill that core professional responsibility, highlighting the absolute non-negotiable safety expectations for staff who administer drugs under supervision. Think radiologic technologists, for example. The complexity here isn't really in the science of the drug itself, but in the rigorous, multi-layered procedure of delivery.
Absolutely. The level of detail required is just immense. Everything from confirming the package integrity to mastering the exact angle of that needle insertion. So our mission for this dive is clarity. We want to simplify this rigorous set of expectations. We want to make sure you walk away with a crystal clear understanding of the must-dos, which we often call the golden rules of drug administration, and alongside that, the kind of mechanical mastery required for complex methods like, say, venapuncture.
And let's be blunt about the stakes here. The sources we looked at consistently cite that errors associated with drug administration aren't just common. They're ranked among the most frequent legal problems that clinical staff, including radiographers, actually face. Precision isn't just a clinical nicety. It's the professional's primary defense against, well, catastrophic patient outcomes and significant legal liability. If the procedure isn't perfect, the consequences can be huge. Immense.
Okay, let's unpack this foundational framework then. The one designed specifically to make error nearly impossible. The golden rules of drug administration. We know them as the 5 rights. And the professional expectation is that these aren't just, checked off a list. They have to be verified, often multiple times, before a drug ever gets near a patient's system.
Yeah, this framework is completely non-negotiable because it forces sequential thinking. It really does. Skipping even one of these 5 checkpoints means you've introduced a fundamentally unacceptable risk into the clinical procedure. They serve as a kind of mental checklist to interrupt the potential for just procedural habit or, environmental distraction to cause an error.
Right. Let's start with the basics and then maybe build on the complexity a bit. Number 1, the right drug. Now, this seems simple, but it demands meticulous verification. You absolutely must confirm that the substance you are holding, reading that label multiple times, precisely matches the physician's written order. This guards against things like stockroom errors, picking up a look-alike, sound-alike drug, or just misreading a label.
And that flows directly into number 2, the right amount. This requires not just accurate measurement, but accurate calculation. It's both. You have to ensure the patient receives the appropriate prescribed dosage based on their specific needs, their weight, and the concentration of the drug you actually have available. A miscalculation here. Well, that's one of the quickest routes to severe patient harm. Really dangerous.
3, the right patient. In a busy hospital environment, confirmation is paramount. Absolutely key. We aren't just asking, are you John Smith? We're confirming identity using 2 distinct identifiers, like checking the patient's wristband and having them state their name and date of birth.
That double check.
Yeah, exactly. This prevents medication meant for one patient from being delivered to another, a type of error that, as you can imagine, has severe legal ramifications.
4, the right time. This is critical. Certain drugs, especially things like antibiotics, anticoagulants, or maybe agents used for a diagnostic procedure, they have to be administered within an extremely narrow, specific time frame. It might be relative to a procedure or a previous dose or achieving a desired therapeutic effect. If a drug is delayed, it can just negate the clinical benefit entirely, or, say in the case of contrast media, it could throw off the whole imaging schedule.
And finally, number 5, the right route. This is where procedural knowledge is absolutely key. If the drug is meant for oral delivery, it absolutely cannot go into a vein. That seems obvious, but...
You'd be surprised.
Right. If it's specified for intramuscular injection, it can't be administered subcutaneously.
Right.
The route affects absorption, speed, and safety. Using the wrong route can lead to anything from just ineffectiveness to, well, severe local tissue damage.
Now, here's where the professional expectation really elevates beyond simply being a good checklist follower. Following those 5 rights is basically the starting line, not the finish line. Our sources explicitly state that the administering professional is expected to understand a broad and, frankly, deep range of knowledge related to the administered substance itself.
Meaning you can't just blindly follow the order if something looks off, right?
Precisely. You must know the appropriate maximum dosage limits. You need to be intimately familiar with the potential side effects, not just the common ones, but the severe ones, too. And critically, you must understand the contraindications. These are the conditions or factors that serve as a fundamental reason to withhold a drug.
Can you give us some examples, maybe some of those high-stakes contraindications that staff absolutely must recognize?
Sure. In the context of medical imaging, a really crucial high-risk area involves iodine-based contrast agents. A severe contraindication would be, say, documented renal failure or seriously compromised kidney function. Why? Because the kidneys are responsible for clearing the contrast from the body. Administering contrast in that scenario can precipitate a severe acute kidney injury. It's very dangerous. Similarly, a documented severe allergy to a component of the drug, or maybe a specific drug interaction with medication the patient is already taking, those serve as non-negotiable contraindications. Recognizing this isn't just following rules, it's exercising true professional judgment.
So the role demands pharmacological awareness, mastery of safe injection practices, and then even after the drug is administered, the job still isn't quite done.
Correct. You have to continuously monitor for potential adverse patient reactions. The drug administration process absolutely encompasses the immediate post-injection phase. The professional needs to be vigilant for any signs of an allergic reaction, localized pain, or systemic changes. The entire procedure, from that initial verification right through to monitoring, is only complete when the patient is stable and the documentation is finalized.
Okay, shifting gears slightly, if we're going to nail the right amount, we absolutely have to speak the unambiguous language of accuracy. And in drug administration, that language is the metric system. It's the universal standard, precisely because it minimizes the conversion errors that, frankly, plague other systems.
Yeah, what makes the metric system so reliable is its logical basis in units of 10. It's just clean. This structure eliminates the need for messy fractions or, complex conversions between, unlike units like trying to convert drams, ounces, and pints you find in some older systems. Nightmare.
Our sources confirm the basic building blocks we need to focus on: the meter for length, the liter for volume, and the gram for mass. Pretty straightforward. However, in the clinical reality of liquid drug administration, the focus sharpens considerably, doesn't it?
Yes, it does. For staff handling injectable or liquid medications, the most common volume unit you'll be using and calculating constantly is the milliliter, or ml. A milliliter is just 1/1000th of a liter. Accuracy in converting between, say, grams and milligrams, or calculating the required volume in ml from a solid powder concentration. That's where the professional risk really lies. Misplacing a decimal point when converting milligrams to grams, for instance, can lead to a tenfold over or underdose of potentially catastrophic error. Simple mistake, huge consequence.
That definitely highlights the calculation risk. Okay, now let's talk about the second half of precision, the documentation mandate. We mentioned that administration is unfinished until it's recorded.
Right.
If it wasn't charted, it basically wasn't done, right? And legally, you have no record of that action.
This is such a crucial area, both for legal defense and for clinical continuity. Our sources mandate the immediate recording of 5 specific items following drug administration. This creates an unassailable record of the interaction. It protects everyone.
So what are those 5 mandatory items that need to be charted right away?
Okay, first, the exact name of the drug. Second, the route of administration, and this is especially essential for differentiating parenteral injections, IV versus IM versus subcutaneous. Third, the precise amount of drug administered, and that includes the units, like 5 millimollar or 100 milligram. Fourth, the exact time of administration. And fifth, the documented patient's reaction to the drug administered. Did they tolerate it well, or were there any immediate localized or systemic issues? You need to note that.
Yeah, I can see why those 5 items are necessary. They create that verifiable history.
Yeah.
Okay, so this documentation mandate leads us directly back to the issue of error avoidance. What happens when, despite all the checks, an error is made?
Sure.
What's the protocol?
Immediate reporting. That is the single most important action. If an error is made, whether it's just a clerical charting mistake or an actual administration error like wrong dose or wrong route, the very first step is to immediately report the incident to a supervisor or physician. Professionals absolutely must follow their institution's specific protocol for incident handling. The professional expectation is transparency, not self-protection. Trying to conceal or correct a charting mistake without supervision introduces immense legal and clinical risk. Just don't do it.
Right. And here's where something seemingly minor becomes a major high-risk factor. Abbreviations.
Mm.
It feels like shorthand saves time, but our sources strongly advise against it.
They do, and the reason is stark: ambiguity. Organizations like the Joint Commission and the Institute for Safe Medication Practices, the ISMP, they dedicate significant resources to publishing do not use lists of unacceptable abbreviations. These lists exist because abbreviations like QD for once daily, which can easily be mistaken for QID, meaning 4 times daily, or even the simple letter U for unit, which can look like a 0. These have repeatedly led to serious drug administration errors, documented cases.
So if the rulemaking bodies are explicitly banning shorthand, what's the ultimate professional takeaway here?
Clarity always triumphs speed. The best practice is strongly recommended. Write out the full word daily instead of QD, unit instead of U. This minimizes the chance of misinterpretation by the next professional handling the patient's chart or order. It safeguards the patient, and it insulates the professional from liability associated with unclear communication. It's just safer all around.
Okay, so we've established the rules governing what is given and how much is charted. The next critical decision, which is also part of those 5 rights, is the where the route of administration. We can organize this into 3 main classes, and knowing the differences really dictates the level of sterility required and the supplies you'll need.
Yeah, understanding these 3 classes is fundamental because the chosen route directly impacts how quickly the drug acts and, importantly, its potential side effects.
Class 1, enteral routes. This is the administration pathway that uses the gastrointestinal tract. Most common route, obviously, is oral, just swallowing a pill or liquid. Simple enough.
But enteral delivery is actually quite diverse. It also includes sublingual administration, where the drug is placed beneath the tongue. This route lets the drug dissolve and get absorbed directly into the highly vascular mucous membranes there. It gives a rapid systemic effect, and importantly, it bypasses the initial harsh metabolic processes of the liver. Similarly, buccal delivery involves inserting the drug into the lining of the cheek, allowing absorption through the cheek membrane. And finally, there's rectal administration, which is often used when the oral route is compromised, maybe due to nausea or the patient being unable to swallow.
Okay. Class 2, topical routes. These involve delivery through the skin or mucosa. We can break this down by the intended effect, right? If a drug is simply topical, it means it's applied to a specific area of the skin and is intended to affect only that localized area, like, a hydrocortisone cream for a rash.
Exactly. But the more complex application is transdermal. Here, the drug enters through the skin layers, but is actually intended for a systemic effect throughout the entire body. A fentanyl patch or a nicotine patch is a classic example. The drug moves slowly but continuously through the dermal layers into the bloodstream, providing a prolonged, regulated dose over time.
Right, and that brings us to Class 3, the one that demands the most rigorous procedural control and sterility, the parenteral routes. This is where we move into the realm of injection.
Defining parenteral is key here. It strictly means administration by a route other than the GI tract, usually by injection. And because this method bypasses the body's primary defense systems, like our skin barriers and stomach acid, it requires the professional to maintain strict aseptic technique. This is non-negotiable. This means preventing pathogenic microorganisms from entering the body during the procedure. It includes meticulous hand hygiene, sterile preparation of the drug, and proper skin cleansing at the injection site. Everything has to be clean.
And within this parenteral class, we have the 4 main routes of injection, all defined by the depth of insertion: intradermal, intramuscular, subcutaneous, and the highly utilized intravenous route. The choice here is based on the desired speed of onset and the type of drug being delivered, correct?
Correct. It's all about getting the drug where it needs to go at the speed it needs to get there.
Okay, since parenteral administration represents the highest technical and safety risk, let's focus a bit more on the specialized equipment required. Naturally, this involves syringes and needles.
Right. And when we talk about needles, their diameter is standardized and expressed in gauges. This is one of those counterintuitive concepts you have to get straight. The larger the gauge number, the smaller the actual diameter of the needle. So a 25 gauge needle is significantly finer, much thinner, than an 18 gauge needle.
And selecting the correct needle length to gauge isn't arbitrary at all. It's a procedural decision based on clear clinical factors. Our sources identify 4 primary influences on this choice.
That's right. First, the viscosity of the drug, basically how thick it is. A thick, oil-based medication requires a larger diameter, so a smaller gauge number, to pass through the needle easily. Second, the site selected for injection dictates the necessary length. You need to reach the right tissue depth. Third, the specific method of injection matters. Intradermal needs a very short, fine needle, whereas intramuscular needs something longer and maybe a bit sturdier. And fourth, the size of the patient. A heavier patient might require a longer needle to reach deep muscle tissue for an IM injection compared to a very thin patient.
Let's quickly review where these 4 injections go, maybe linking the location to the desired absorption rate.
Sure. Intradermal injections are placed just within or between the layers of the skin. Think PPD tests for tuberculosis. Absorption is extremely slow, which is what you want for that kind of sensitivity testing. Subcutaneous injections go beneath the skin into the fatty layer. Absorption is slower than muscle, which allows for sustained delivery, like with insulin injections. Intramuscular injections, or IM, are placed deep within the muscle tissue. This route is often associated with a rapid onset of action because muscle tissue is highly vascularized, lots of blood vessels. This allows for quick diffusion into the circulatory system. It's often used for higher volumes of medication or certain vaccines that need to work fast.
And finally, the one most critical for procedures like contrast administration and imaging. Intravenous or IV administration directly into a vein. This gives the fastest possible onset of action because the drug immediately enters the central circulation. Bang, it's in the bloodstream. This can be delivered rapidly as a single dose, which we often call a bolus, or as a slower, rapid delivery over a defined short period.
Now, in terms of safety equipment, the field is constantly improving, thankfully. The angiocath, for instance, is specifically highlighted in our sources as a safer alternative compared to older, rigid needle systems for doing venipuncture. It's basically a flexible catheter inserted over a needle. Once the vein is accessed, the needle is withdrawn and shielded, leaving only the soft plastic catheter in the vein. This dramatically reduces the risk of vessel trauma and, crucially, accidental needle sticks for the healthcare worker.
And speaking of needle sticks, the emergence of needleless systems has been a huge safety revolution in 5E drug administration, hasn't it?
Oh, absolutely. These systems are pretty much standard now because they drastically reduce the greatest single source of risk to the professional, those accidental needle sticks. What's critical for any professional connecting to an existing IV line is absolute certainty regarding system identification. You have to know what you're connecting to. Needleless systems use a specific connection, often called a HEP lock or a similar port design. And crucially, they have a distinguishing visual feature, a white ring on the port. That white ring is a universal signal. It identifies it as a needleless system, and under absolutely no circumstances should a standard needle be used to access that port. Using a needle will damage it and risk contamination. It's an immediate visual safety check that prevents dangerous accidental punctures. You just have to look for that white ring.
Okay, so venapuncture. This is a skill that really ties all these safety protocols together, especially in fields like radiology, requiring the introduction of agents like contrast media. It requires absolute mastery of the protocol, starting with the procedure before the needle even touches the skin.
Yes, the procedural integrity begins with the professional protecting themselves and the patient. You absolutely must adhere to all universal precautions. That means thorough hand hygiene and proper personal protective equipment, like gloves, before attempting any parenteral administration. That's the inviolable baseline of aseptic technique. Non-negotiable.
Then we move to the checks. Check the order, confirm the drug and dose, and then rigorously adhere to patient identification.
Yes, checking 2 patient identifiers is mandatory, never just one. Then you explain the procedure clearly to the patient. Transparency really helps reduce anxiety, and you perform one final verbal check for known allergies or contraindications that might somehow have been missed in the chart review. Just ask them directly.
Okay, once you're satisfied, the supplies are prepped and ready.
Exactly. Assemble everything needed right there, put on your disposable gloves, and identify the optimal puncture site. In the forearm or hand, you're looking for veins that are visible, palpable, meaning you can feel them, and relatively straight. Avoid joints if possible. That chosen site must be meticulously cleaned with an antiseptic solution, like an alcohol swab. Wipe the site thoroughly, usually in a circular motion, outward from the center. And then you have to let the disinfectant air dry completely. Don't blow on it, don't wave your hand over it, let it dry. Only then do you apply the tourniquet above the site to engorge the vein, making it more stable and visible.
All right, now we enter the highly technical phase, the actual insertion technique. This needs precision.
It really does. It's a matter of millimeters and degrees. You must stabilize the vein by gently pulling the skin taut below the intended insertion site with your non-dominant hand. You hold the needle, or angiocath, with the bevel facing upward, that sharp angled tip. This orientation allows the sharpest part of the needle to cut cleanly through the skin, not tear it. You insert the needle next to the vein, aiming slightly towards it at a very specific 15-degree angle relative to the skin surface. Then you gently advance it into the vein.
Why is that 15-degree angle so critical? Why not say 45 degrees or just 5 degrees? What's the reasoning?
Good question. That 15-degree angle is kind of the sweet spot dictated by typical skin thickness and vein depth in common sites like the arm or hand. If you insert too steeply, say 45 degrees, you greatly increase the risk of puncturing straight through the posterior, the back wall of the vein. That causes infiltration, hematoma. Basically, you've gone too far. If you insert too shallowly, like 5 degrees, you might just slide along the top of the vein, or the needle tip might only partially enter the lumen, making entry difficult and increasing the chance of the needle slipping out or causing infiltration. So the 15-degree approach allows the bevel to smoothly penetrate the dermal layer and then the vessel wall without hopefully transfixing the vein. It gives you the best chance of a clean entry.
Okay, makes sense. Now, the moment of truth is verification. How do we know we successfully hit the target, that we're actually in the vein?
The key sign, the absolute confirmation, is verifying the needle is correctly seated in the vein by looking for blood backflow into the tubing or the hub of the catheter. This is known as flashback. That little flash of red blood is immediate, visible, and it's the non-negotiable confirmation of successful venapuncture. You need to see it.
Right. Once that confirmation, that flashback is established, what's the protocol immediately before pushing the drug?
Okay, as soon as you see flashback and advance the catheter slightly, you immediately remove the tourniquet. Pop the tourniquet. Leaving it on during injection can increase the pressure within the vessel unnecessarily and might contribute to extravasation or blowing the vein. Then, as you slowly inject the medication, you must continuously inspect the site visually for any signs of swelling, redness, or ask the patient about any burning or discomfort. Watch and listen.
Okay, let's jump straight to the potential worst-case scenario during that injection. Extravasation. This demands rapid, correct action. What is it exactly?
Extravasation is the discharge or escape of fluid. Often it's contrast media in imaging, or maybe a vesicant drug that's corrosive from the vessel directly into the surrounding tissue. It is a serious complication because things like contrast media are hyperosmolar, meaning they draw fluid. Their escape can lead to significant localized vasoconstriction, which is narrowing of blood vessels. This causes pain, swelling, and in severe untreated cases, it can lead to sloughing or necrosis tissue death, which might even necessitate surgical intervention later on. It can be really bad.
So if that swelling or redness is observed during injection, indicating extravasation or infiltration is happening, what is the mandatory, non-negotiable first step?
Stop. The mandatory first step is immediate cessation of the injection and the removal of the needle or catheter. Do not continue to push the drug. Stop the procedure immediately. Get the needle out.
Okay, needle's out. How is the injury managed right then and there to prevent permanent tissue damage?
You apply firm but gentle pressure to the injection site with gauze to minimize further fluid spread. Crucially, the sources consistently recommend following this with the application of warm, moist heat to the affected area. The purpose of the heat is therapeutic. It causes localized vasodilation, opening up the blood vessels. This increases blood flow to the area, helping to disperse the escaped fluid and counteract the vasoconstriction caused by the hyperosmolar contrast or irritating drug. In rare, severe cases that don't respond well to heat, the sources note that an antidote might actually need to be injected into the extravasation site by a physician to neutralize the drug's damaging effects, but warm compress is the standard initial response.
Got it. Okay, shifting slightly from single injections to larger volumes. Venapuncture often sets up for a single-dose delivery like a bolus. But what about drip infusion, where fluid is administered over, say, hours?
Right. Drip infusion involves administering large volumes of fluid, maybe saline or medication mixed in a bag, over a predetermined period via an IV assembly tubing, drip chamber, etc. This requires careful flow rate regulation, and that's often done using electronic devices.
We use IV pumps and controllers for this purpose. Can you clarify the functional difference between them?
Sure. An IV pump typically regulates the flow rate very accurately, often using a mechanical mechanism that actively pushes or pulls the fluid through the tubing and might monitor resistance electronically. They're quite precise. A controller, by contrast, regulates the flow by gravity, basically counting the drops falling into the drip chamber and then automatically compressing the tubing slightly to speed up or slow down the rate to match the setting. While both achieve regulation, the crucial awareness for the professional, regardless of the device, is paying extreme attention to the pump and controller alarms.
Yeah, if that alarm sounds, it's not just background noise, is it? It's an alert that needs attention now.
Precisely. If the infusion fails to flow at the prescribed rate, maybe because the bag is empty or the line is occluded, kinked, or clogged, or perhaps the patient has moved and bent their arm, the alarm demands immediate investigation and intervention. Failure to respond promptly can result in the patient receiving fluid too slowly, which might be a subtherapeutic dose, or perhaps more dangerously. If an occlusion is suddenly released, they could get the fluid way too quickly, risking fluid overload or even shock. Clinical awareness of the equipment's operational status is just as vital as getting that initial needle insertion right. You have to monitor the whole system.
Wow. Okay, this deep dive has really underscored the truth that drug administration is just this high-stakes blend of clinical knowledge, calculation precision, and real manual mastery. The five rights, right amount, right patient, right time, right road, they absolutely have to be the reflexive framework governing every single procedure. No shortcuts.
Absolutely. And beyond just the checklist, the professional has to possess that basic pharmacological knowledge concerning drug actions, potential side effects, and those critical contraindications we talked about.
Mhm.
Technical skills like venapuncture are clearly non-negotiable, and mastery of protocols like the extravasation response is vital for protecting patient health when things inevitably sometimes go wrong.
So what does this all mean for the professional taking on this responsibility? We've detailed the countless controlled actions, the correct drug, checking the label 3 times, the perfect 15-degree angle, the precise documentation, all the things that we must execute to administer a drug safely. Yet the source material constantly reminds us that even with human action perfected, numerous biological factors affect the patient's eventual response, which may still result in an undesirable outcome.
Exactly. The entire system of protocols, the five rights, the checks and balances. It's all designed to control every variable that can be controlled by human effort and decision making. But there are always factors outside our immediate control.
Right. Therefore, considering all the detailed procedure we absolutely must get right, think about this. We've discussed the detailed actions we must take to administer a drug safely. But when that administration is perfectly executed, textbook perfect, yet still problematic for the patient, resulting in an unexpected adverse reaction, what specific underlying biological mechanisms do you think are most often responsible for those outcomes? What makes the interaction complex despite our procedural perfection? That is the unpredictable frontier of patient physiology that we must always be ready to face, even when we do everything else right. Something to consider.